Welcome to Politics Done Right. I am your host, Egberto Willies. This is the progressive program that will take the mystery out of politics. This is the program that will encourage you to make sure government becomes we the people. Whether you are liberal, conservative, or otherwise, you get to air your point of view. Remember, you can also send me a tweet to EGBERTOWILLIES. That is, at Egberto Willies. Let us engage. It is Politics Done Right.
1, 2, 3, 4.
All right, welcome to Politics Done Right with Egberto Willies on the bus. Today I am honored to have a special guest. You know why? Because we're doing business. So who are we with today but Melissa McChesney? How are you doing, my friend?
I'm doing great. Thank you for having me.
What are we doing on this bus?
So we got up at 5 a.m. this morning and left from Houston to go to Austin for a rally to support Medicaid Expansion and to get it on the ballot, because if the Texas legislature isn't going to do it, then let the voters vote and let us vote to get it done that way.
Are you telling me that in Texas, even though we are paying a hell of a lot of money to the government to allow everybody to have health care,
that's right,
we are not supporting that in Texas?
That's right. So under the Affordable Care Act, it made it where the Medicaid program could be expanded to any person with an income below 133% of the federal poverty level. But because of a Supreme Court decision that essentially made it optional for states, and Texas chose not to take that money. So while we pay out our federal taxes, those tax dollars go to other states to support healthcare for their low-income population, but they don't come back here. And we have 1 million Texans who currently have no access to affordable healthcare.
Now, I really thought that Texas was considered a fiscally responsible state. Is there any fiscal responsibility in that sort of behavior?
You know, it doesn't make a whole lot of sense from an economic perspective, because the way that it's set up, for every dollar that's spent on this healthcare, the federal government pays 90 cents of that. The state only has to put in 10 cents. So we call that the 90-10 match. So the federal government will pay 90% of these costs, and the state just has to kick in that additional 10. And so really, it's a very affordable way from the state's budget perspective to pay for that health care. And then what are we losing if we don't do that? We have a lot of uninsured folks, and they end up, everybody gets sick. Every health care is something everybody needs and everybody will use at some point. So at some point, those people will get sick, they'll go to an emergency room, and then that care that they have to receive in the emergency room, first off, it often doesn't fix the problem. It just gets them into a more stable state.
Yeah.
But then it also costs so much more. Imagine how much cheaper it would have been if we had just given them health care and let them go to their primary care physician and take their health care needs taken care of before they become urgent. And so we end up with this thing called uncompensated care, that if you live in a big city, your health department is paying so much, your hospital district is paying so much in uncompensated care, and that's coming out of your taxpayer, out of the pockets of taxpayers. So you're paying for this twice. You're paying your federal government for Medicaid expansion that's not coming back to the state.
Right.
You're paying for the uncompensated care that the hospitals in your hospital district are providing, and it's all so much more expensive than if we just gave people who don't have access to health care, and they don't have access to it because they have jobs that don't provide it. It's not because they're not working. They're working. They're just working in industries where they get hourly wages, where you don't get benefits.
Right.
And so let's provide them health care, and let's make sure that they're getting that less expensive, better care through preventive care.
Now, isn't it true as well that we have a disproportionate effect? This also has a disproportionate effect on the rural areas.
That's
vis-a-vis the same people that are stopping this from coming to fruition or hurting their own people?
Yeah,
why don't you explain about
Yeah, sure. So it's
that?
really ironic because what we have a lot of legislators where their districts are in rural areas, and they have been on this platform of sort of an anti-Obamacare platform for years. They've been running on it. But the irony of the situation is that in those rural districts, there's actually a higher uninsured rate than in your urban areas. So they actually have more to gain. Their constituents have more to gain in their area, but they are sort of ironically still voting in people who are supporting blocking this legislation. And part of that, another thing that's playing out there is that we also have hospitals in these rural areas that are having a hard time keeping their doors open because there are not enough people that have health care in the rural area.
Now, there's a point where ideology, we know the ideological behavior of the right. Mm-hmm. You would think that after a certain point, because, let me back up. You mentioned earlier that we are only responsible for 10% of the cost of Medicaid expansion to affordable care. Isn't it true that the first 3 years was actually 0%?
That's right. 10% was, it started at a much higher percent, and the idea was to help states sort of ease into the process. They didn't want this to be this huge line item in state budgets every year. They know that states have to balance their budget.
Right.
So the idea was to ease them into the process, but we're a little bit behind in that now. But yeah, 90 was the lowest or the most that we were ever going to have to pay, and it started out much higher. That's right.
Now, interestingly, these hospitals that are closing would further make the price of healthcare more expensive for not only the people in the rural areas, but the people in the cities or areas that have it, given that those people would be coming to the hospitals.
That's right.
In those areas. Is that correct?
That's right.
So what then is, first of all, who are you with?
I work for the Center for Public Policy Priorities. They're based in Austin, but I'm remotely based in Houston.
In Houston. Mm-hmm. How are you going to convince these politicians to do the right thing?
So I will say that it's been, we've been going through this process. We've had the option to expand Medicaid since 2014, and Texas has chosen not to. So that we've gone through multiple legislative sections in 2013, 2015, 2017, now we're in 2019, and nobody's done anything. And so the rally that we went to today, one of the things that we're calling for is, okay, if you don't want to do something in the Capitol, then you need to let us put it on the ballot, and you need to let the voters vote for it, and they will show you that the majority of Texans want this, want to expand Medicaid. We've seen the polls. The majority of Texans support Medicaid expansion. They support providing that access to care for your low-income populations, because it's not just good for the people who are going to get the care, it's good for the communities as a whole, and it's going to lower our healthcare costs as a whole.
And it lowers the healthcare premiums for everybody. Texan. Is that correct?
Right. That's right. Everybody gets a lower healthcare premium because you're not paying for that. Because right now we're paying so much more when people have to access care in hospital, in emergency rooms, instead of going to their primary care physicians.
Now, so given that you want it on the ballot, what's the procedure to get it on the ballot? Do we know that?
I don't know that, and I'm sorry that I don't know that.
No, that's not important, but there are policy people to do that.
That's right, and I'm sorry, I'm just not, that's not my area of expertise, but I do know that there are a few, they're not called bills, they're called resolutions.
Right.
And I'm sure that we can get those numbers for you before the end of the show, because everybody in here has a piece of paper that has them on them. So there are a couple of resolutions that were authored, I know, by John Boosie, by Senator Nathan Johnson, and then Representative Israel. And they spoke at the rally today, and those resolutions would then, I think, if they're a constitutional amendment that allows it to go on the ballot.
Well, I mean, that is something that we hope gets done. Now, tell me, what are your hopes? What are your expectations? Timeline? What do you think? Because you've been doing this for a very long time.
Yeah. Well, the bill filing, we've seen a lot of bills filed. So I talked about the 3 resolutions, but there have been something like 10 or 15 other bills that do some version of Medicaid expansion. And it's interesting, I want to point out that a lot of people have said, I hear all the time, well, why can't we just do something like sort of a Texas way to expand Medicaid? Look, if you want, I support straight Medicaid expansion. I think that that's the best way to do it. You want to look at a good model for that. Louisiana had a great model for Medicaid expansion, but there are more conservative approaches.
Right.
And there are plenty of bills out there that have those approaches. So it's not for lack of ideas. There are plenty of ways to do this. Arkansas had a very interesting model where they put some of their expansion population into the ACA marketplaces and paid for their premiums using the dollars instead of giving them Medicaid. There are other approaches that we are welcome the discussion to talk about, but I think it's important that we're talking about them. So we've got a dozen bills or so at this point. The filing deadline is this Friday, and I'm sure we'll see some more Medicaid expansion bills by then. But we've got a lot of work to do this session, and so I think it's important that if you are a person who supports Medicaid expansion, you need to be picking up the phone and calling your representatives and letting them know, because we also, I'm sure you talk about on your blog, we've got to work on school finance this session. There's a lot of other pieces, but Medicaid expansion is one of the things that is, they say 2 birds with 1 stone. This is like 10 birds with one stone.
Right.
Because you talk about mental health care, we've got a mental health care crisis in Texas. You want to get better access to mental health care? Give people insurance. We talk about the maternal mortality crisis in Texas. What is the way to solve that? We make sure that they have coverage and therefore care before, during, and after their pregnancy. Medicaid expansion provides that to young people, to young women. So while we have all of these competing priorities at the legislature, Medicaid expansion can address a lot of the issues that people are identifying in Texas. And if you don't mind, I'm just going to say one more thing.
Oh, I want you to say whatever you need to say, because we need to get this
earlier
out.
We said that Texas has the highest uninsured rate in the country, and that's true. And this year, we now have the highest uninsured child rate in the country. So
hear that.
So even though Medicaid expansion is an expansion to adults, right? This is coverage of adults. Research shows so very clearly that when you give parents coverage, their children are more likely to get covered as well. And 2/3 of the people in what we call the coverage gap, 2/3 of the people that would get that Medicaid expansion if we took it are parents.
Right.
So we get them covered, we get their kids covered, and so if you care about children's health, you should care about Medicaid expansion as well.
Now, you mentioned about we have the highest mortality rate for women, pregnant women, I think. Or
we
women.
have a very high maternal mortality rate, that's correct. So, and we've seen a lot of studies that have been coming out over the last few years. This is especially true of African American women. They're dying at just unprecedented rates postpartum, and it's not always immediately postpartum. Sometimes it's a few months postpartum, but from complications that happen during their pregnancy. And currently today, if I get Medicaid as a pregnant woman, I can get that as soon as I get pregnant, and I can keep that coverage for 2 months after I give birth. But then 2 months later, you're done.
Right.
And I'll just tell you a personal story. I have a son. He's back there on the bus, and he was born 10 months ago. And about 5 months in, I actually was diagnosed with hypothyroid. It turns out 10% of women, 5 months postpartum, it starts right. It's almost like clockwork. 5 months postpartum, they end up with having thyroid problems.
Wow.
Yeah, and sometimes they don't even recognize it. They think,
Right.
oh, I don't feel good because I don't sleep well because I'm a baby, right? But I actually ended up with a thyroid problem. If I were a woman, a low-income woman who had Medicaid, I wouldn't have been able to go to my doctor and get treatment. And it's fairly easily treatable through just a pill. I take a pill every morning now, and my thyroid levels are back up, and I'm feeling much better. I'm much better able to take care of myself and my child. But if I were a low-income woman on Medicaid, I wouldn't have been able to get that fairly easy to address health issue that was related to the fact that I had just had a baby this year. I wouldn't have been able to address it, and so it's really important. That's just one example of why women need that coverage, and so this Medicaid expansion is one of the mechanisms I'll give up the hot seat.
Yes, that was Melissa, and as you can see, we are on the move here in Texas. We're making sure that things happen. Our next guest, of course, is El Señor Daniel Cohen. Daniel Cohen, come on in. Come on.
What do you want, Egberto?
How you doing, Daniel?
This guy woke me up from my nap over off camera.
Nobody sleeps on this bus when Politics Done Right is on, especially not Daniel Cohen. Daniel Cohen is the president of Indivisible Houston, and of course I had to have I call him my brother, but it's more like my son. Okay, but anyhow,
my dad's a listener to the show.
I told him that already, so he knows that. He was happy when I told him that. Anyhow, folks, we have Daniel Cohen. Daniel,
hello, y'all.
Daniel is one of our most prolific activists in Houston, Texas. He makes sure that things happen. Talk to me about what you thought about what we did today.
I think it's great. Right now, as many people may know, it's 140 days every 2 years when the legislative session is going. So today was a rally for Medicaid Expansion right out in front of the Capitol. Various people went to different offices, talked to staffers and legislators about different Medicaid expansion bills that are on the table. And I think showing that there's a presence means that they have to pay attention to you. And if they don't pass Medicaid expansion, then they're going to wear the vote on their foreheads.
Well, I like that. They wear the votes on their foreheads. How are we going to implement? How are we going to make sure that happens, Daniel?
You got to keep up the pressure and keep calling them. But the other thing you can do is plug in with organizations that are continuing to lobby and come out to Austin. You can keep an eye on bills, see when they're getting a hearing. If you live in the Austin area, or even if you don't live in the Austin area but you're able to get away, you can go and testify on the bills.
Now, you've been up to Austin several times.
Past, not this session is my first time.
I mean the session is not all. Well, like it's been on for a while, but
a little bit.
It's been for a little bit, but I think the end of getting bills online is Friday. What Melissa just told us. Let's get beyond. We spoke earlier about Medicare for all. I'd like to know what are your thoughts on Medicare for all. Of course, we're here for the Medicaid expansion to the Affordable Care Act, but Melissa, I think, covered that pretty much in detail. What are your thoughts about Medicare for all? What are your thoughts about whether this needs to become a litmus test or not? What are your thoughts?
A litmus test for what, the 2020?
Yeah.
I think that we have to have a discussion about what everything should look like. I'm a proponent of making sure that everybody has access, I'm not even going to say access. I'm a proponent of healthcare being a human right. That everybody should get it. I think that if you keep people from it particularly, and if you price them out of it, it's the equivalent of keeping a candy bar slightly out of length from a starving person. I think it's unconscionable.
Right.
So I think that there needs to be a real discussion about how we keep that from happening. I mean, is it a litmus test for individual primary members? Obviously, don't take this as a cop-out, but it's obviously up to the voters.
Right. But you're right. That's really the only answer, right? But
they're the ones.
I guess my question was: is it one of your litmus tests?
It's an extremely important issue to me, and I don't want to see profits in the healthcare industry. But I also listen to the arguments of healthcare professionals, because we should always listen to the arguments of healthcare professionals. Because frankly, right now, right, to talk about something else that's related to this, right? There's a lot of people who are pushing like a post-truth idea of things.
Explain that, because a lot of people don't quite understand when you say that.
Yeah, so there's two assaults on truth. There's one, which is the exclusion of perspectives, which means that you don't have all the data necessary to make the decision that you need to make because you've kept people out of the discussion point because you've excluded their perspectives.
Right.
But the other assault on truth is when you consider all perspectives to be equal no matter what. Because there are charlatans and BS artists out there who push forward perspectives that shouldn't be considered. Alex Jones's perspective on 9/11 shouldn't be considered.
Right.
It shouldn't be on the table. It's not scientific. It's not accurate. It's not reasonable. It's not logical. It's not philosophically sound. There's no reason that we should assess it. Now, a lot of that kind of perspective, believe it or not, originally came from a strain of the postmodern left. Right? There was a guy named Jacques Derrida, right? Became very popular in philosophical circles. And Jacques Derrida said that all texts that you read only have meaning because you impose text the reader imposes meaning on the text.
Right.
Now the problem with that is that another structuralist who was named
to donate a couple bucks for a tip for the bus.
Yes, we're live right now, but we'll do so. No, that's not a problem.
Another structuralist who was named Leman, right, who was of a similar school of thought, claimed to be this Belgian resistance fighter. But years later, it came out that he was on the other side of the war. That he had written more than 100 anti-Jewish articles for a Third Reich periodical. Now, his friend Derrida's interpretation of this was that, well, we could impose whatever meaning we want on these articles, so we'll just impose that they were ironic. They're not ironic. The man wrote them as hateful prejudice propaganda, which is what I'm getting at is this, right? Now the right has picked up postmodern, post-truth ideas that all perspectives are even and that we just impose our meaning on whatever's there. But that's not the way that it actually is, right? So we need to, whenever somebody has data and facts that we should assess, we should always assess them and always talk about them, because the mere activity of assessing facts flies in the face of charlatans such as Trump.
Well, you know what is interesting is you opened, what I always tell people when they come to Politics Done Right is we normally have something that we're going to talk about, but sometimes a guest always does something like you just did.
Go sideways.
To change a conversation into something that tickles me. And if it tickles me, we're going to talk about it.
All right, so let's talk about it.
Let's talk about it. And guys, we're going to go back because we have a great doctor on the bus that will be here to discuss Medicare for All. But before, I want to test my brother here a bit on what he's talking about. Contrast that with ideology, what you just said with ideology.
Yeah, sure.
Because there's a point where people have an ideological belief and they don't necessarily want to change it, but based on what you're saying, given that we want to make sure that facts are in fact facts, how do you line those two up together?
Chomsky and Zizek had an argument over what changes people's minds. And the basis of it, and I'm paraphrasing, is basically Chomsky said, bring the facts and the truth will set you free.
Right.
Zizek said ideology is more complicated than that.
Right.
I think Zizek, unfortunately, is probably right. It would be nice if we just provide the evidence and things change, but it's not the way that it works. We know that communications, we know that sales, we know that persuasion is part of all of this. One thing that the left can do, ideologically speaking, to get its values out there and to make sure that people are succeeding, is assess where it's investing its money and what kind of skills it's investing in.
Right.
So all of the think tanks and organizations, nonprofits, things like that on the left out of college and all the ones on the right treat the kids that are coming and the people who are going to be the adults, the fighters of the future, the professionals of the future differently. There's lower wages on the left. Not to mention the majors that we skew toward are different, right?
Right.
And it makes sense, right? Because if somebody's like, yeah, I don't really trust the system, why would they want to become a business major? But the problem is that if you're not a business major or an engineer, you're missing this kind of like structural thinking about systems, processes, organizational systems and processes that can be really good for organizing. So if we only focus on communication, then we miss the whole structural side. If we only focus on structure, then we miss like the ability to communicate. You kind of have to have both. And I think that building up those skill sets is how you eventually recognize and provide opportunity for large-scale ideological changes.
Okay, now I'm going to go not deeper, but ask you to be an engineer now.
I'm a writer by trade.
I know that, but here's the thing. The difference between a scientist and an engineer is as follows. The scientists know everything in detail. Each individual scientist know their profession perfectly. The engineer takes the sum total of the knowledge attained by others and creates something useful for society. What you just said was pretty in depth. How do we turn that into action for the progressive movement?
Well, if somebody's this is really organizer talk, right? More than anything else. So
exactly.
If you are an engaged organizer, if you're an active organizer, if it's something you do regularly, it's something that you want to do, you need to shore up your skill sets. So if you don't know anything, if you're a writer, you're like a speaker, you're an orator, you know how to catch the press or things like that, but you don't know anything about compliance, you can't tell me the difference between a PAC or a C4 in your state and like what goes into that. You don't know how to raise money. You don't know and not necessarily for big donor money, but you don't know how to make finances work. You need to shore up that weakness and make sure that you're not missing the boat on that. Because if you've never filed before, like if you've never filed an organization before, if you don't know what goes into filing an organization, if you haven't gone and found some of the nonprofit lawyers out there and sat down and talked to them about organizations, then you're going to miss the boat. So what I would say is, if you're an organizers in the progressive movement should think about what they're good at, what they're not good at, shore up their weaknesses, and then take their new some knowledge to the movement. And from the other side of things, those who are investing in the movement should be investing in education, knowledge, salaries for people who are coming out of school, right? If you're someone who has deep pockets and you really care about the ideology of the left, the progressive ideology succeeding, and you're dumping money into different things, right? You might say, you know what, I'm going to put a bunch of money into this campaign, right? That might work, it might not work. It's actionable, it feels good, because if that person wins, then you put your money into something and it actually worked, right? But what you're missing is that if you put, I don't know, let's just pull a number from the sky, $300,000 into a campaign to get, I don't know, a district attorney in a giant county elected or something like that, or an attorney general in a small state elected or something like that. Well, that's 6 very robust salary packages for somebody who's coming out of college, who's going to spend their entire career growing in an organization, organizing in the community, learning different skill sets. And what's going on with those people right now is, one, a lot of them are gravitating away from organizing, and instead they're like doing whatever it is that they can to make ends meet because they have to, right? Because they've got college debt and everything else. And two, when you're not paid and you're just a volunteer a lot of times, especially if you're younger, then you don't really treat it like a job. So you're not really looking at benchmarks, milestones. Then that's not a slight to volunteers or the organizers or anything like that. It's a slight to the system. It's a critique of the system that we're not taking that money and putting it back into leadership development. Whereas the right puts it into leadership development all the time.
That is constantly. They invest in everything. They invest in exactly what is on think tank, their own media, everything.
Absolutely.
So that is what that is prescient. And folks, donors, contributors out there, understand what Daniel is saying. That is very important. And by the way, that's why he's so prolific in Houston, and that's why Indivisible Houston is going places. Daniel Cohen, it was a pleasure.
It's a pleasure.
So
check us out
check us out
at indivisiblehouston.org. You can also follow us on Instagram, Twitter, Facebook. You can sign up to our email newsletter on the website, which is again indivisiblehouston.org. Thanks.
One more time,
indivisiblehouston.org.
That was Daniel Cohen. Thank you very much, Daniel. Folks, so you understand what we're saying. This is very important stuff. Now, we have a doctor that came out here with us to defend Texans, to make sure that Texans are taken care of, to make sure they get their the Medicaid expansion to the Affordable Care Act. So we're going to first talk a little bit about that, some of his experiences. But secondly, I am going to probe his brain about Medicare for All. I hope that he's going to be able to enlighten me with certain things. I hope to get a balanced opinion. So with us, we have El Señor Cedric Dark. Cedric Dark, how are you doing today?
Good, how are you?
I am doing fine. Thank you very much for doing the interview today. No problem. But guess what? You have to speak up because we're on the bus.
Yeah, we're on the bus, and I'm a mumbler, so sorry.
And this doctor is a mumbler. I wonder what he's telling his patient. No, I know. He's a darn good doctor. Anyway, Doc, let me ask you a few questions.
Okay.
What made you come on to this rally? What made you come up to Austin like we're doing here to help out the folks in Texas?
Because my personal mission is universal health care in the United States. That's why I exist.
Now, so that was always your passion, universal health care?
Pretty much.
Now, how long? Why? Yeah.
I don't know. I would say maybe at least going on a little more than a decade. Actually started a blog back in 2008.
Right.
Called Policy Prescriptions, www.policyrx.org.
Repeat that because we want to make sure people hear it.
Yeah, www.policyrx.org. So you can go there, and essentially what myself and about 24 of my colleagues have done over the past 10 years is we look at science and research and we say, hey, how should this direct the policies that impact healthcare? And obviously, one of the things that we know needs to happen is making sure that everybody in the U.S. has coverage.
Right. Now, you see, I want you to detail to us some of the stories that you've spoken about with what you've seen from the indigent in your OR. Dr. Dark is an OR.
ER.
ER. What am I saying? ER. What do you call it? ER resident, ER doctor, an ER doctor, and he has a history to tell. So tell us a little bit of what you see and why it's so important that we get this Medicaid expansion to the Affordable Care Act.
Yeah, I mean, one of the things that we wound up seeing a lot of times is people that have delayed care. Because they don't have coverage, they decide not to come to the hospital or see a regular doctor, or they can't see a regular doctor. And so eventually they show up to see me in much worse condition than they otherwise would be. And so we see things ranging from folks that have high blood pressure that have never got it controlled until they come in with a stroke or a heart attack, or we see people that have like end-stage cancer that probably if they'd seen a regular doctor in the office, they could have had a screening test like a colonoscopy or a mammogram, and they'd be well treated and maybe have a full productive life, but instead they're kind of coming in with terminal cancer by the time they see me.
Now, is there any particular story that you can think of that really made an indelible impression on you?
I mean, there's one guy I remember, he was sitting in bed 6 over in our ED. And he
What's
was
ED?
Emergency department,
Okay.
sorry.
Yeah.
So he's sitting in bed 6, and he's been feeling weak for, going on a couple months now, been feeling weaker and weaker, but and the guy like climbs trees, cuts trees down, that kind of thing. But just for whatever day, I think he passed out that day.
Right.
He was so weak, and we checked him, and his blood count was super duper low. The reason his blood count was super duper low is because he had colon cancer, and had been bleeding slowly, and wound up having a tumor that probably could have been treated a long time earlier.
Right.
So it's stories like those that stick with you, and you think about it. Hey, if this guy just again that's checked out, if he had coverage, if he had Medicaid or something else, where he could have seen a doctor in the office, and they could have figured that out a lot earlier.
Now, is Medicaid expansion something that you've seen popular with doctors in general, or not?
I think there's been mixed perspectives on it a little bit. It depends on somewhat the political persuasion of the doctor, but I think overall, when many physicians look at it, I think we want all of our patients to have coverage of some type. And especially where I work at a public hospital. If we could get, let's say half of our patients to go from having no pay to some kind of pay, that's going to put hospitals in a much better financial footing. I was listening when Melissa was talking, and I think she mentioned rural hospitals closing.
Right, tell us a little bit about that. Yeah.
I mean, it's dollars and cents, right? If you have people that go to your hospital that don't have coverage, in the ER we see them anyway. We see everybody, regardless of why they show up. We see them regardless of when they show up, and we see them regardless of if they're ever going to pay us. And so what happens if you think of a rural hospital, small hospital, that is trying to stay afloat, if half of their patients don't pay them, eventually they're going to close, right? And it's not only going to affect those patients, it's going to affect all the patients in that community, even if they have insurance. They won't be able to get access to care as well.
Right, because there's no hospital.
Because there's no hospital now.
Right.
But let's say on the other hand, we say Texas, let's expand Medicaid. So all those rural areas in Texas now, if you took just, a fraction of those people, and instead of half of your ER population being uninsured, now it's a quarter that's uninsured. You still have half of them that have private coverage. You have 75% that are paying into the system. Now you might be able to sustain the other 25% that don't. And that's something that makes a lot of sense to a lot of people, including physicians, including hospital administrators. We just need to get that through the heads of the Texas legislature so that they'll get wise to it and figure out it makes financial sense.
Now, I think a lot of the problem is ideological, why they, even though they know that they're killing their citizens, that they still won't do it. How do you think we can break that? Don't you think doctors like yourself have to play a much more active role? One of the problems that I have, doctor, is the following. You guys have taken an oath to serve and an oath to cure. You've taken that oath. And in a state like Texas, where we have politicians that what I call committing virtual murder, because the fact that you have a solution and you don't use it and it allows others to die, that in legal terms would be called at least manslaughter. My statement to doctors, and it's sort of an admonition, why don't I see doctors more like you, more up in arms and doing something about it?
Yeah. Well, first of all, we had a couple doctors at the rally, just so you know.
No, absolutely.
So I mean, there are some of us there, but I think there needs to be more of us being vocal. Part of the reason why we're not, I think, number one is doctors are comfortable, and so it's not going to bother us to sort of keep the status quo. But there are those of us that do realize that there's more that we should be doing for our patients and not just for ourselves.
You saw an oath.
You see us there.
You saw an oath. Sure, there's an oath there. I mean, I've always had insurance, always. That never not allowed me to have the empathy for those who didn't. And that is the most concerning portion, I guess. I mean, and I'll tell you something else when we get into the other subject.
Yeah.
That is one of the reasons you don't see me have too much care. I shouldn't say care, but concern when I hear doctors say, well, if we go for something like Medicare for all, our salaries will fall. For the exact reason that you've just said. You've said, well, they're very comfortable, so who cares? Let's talk about Medicare for all.
Okay,
now.
sure.
All right?
Yeah.
I am a strong proponent not only of Medicare for all, but likely even a bit more generous than what Jayapal has proposed, Representative Jayapal has proposed. You share some concerns, some legitimate concerns. Yeah. And I think people should not just listen to one point of view, and I have my point of view. I think people ought to hear all points of view because ultimately it is us all that's paying the bill. And therefore all of us must have an input to come to some sort of a resolution. Tell me your thoughts, first of all, on what would be considered standard Medicare for all.
Well, first of all, I don't know how much more generous you can get other than the bill that was dropped already. Because I listened, and I'm going to put out a plug for the What the Health podcast from Kaiser Health News.
Okay, go for it.
I listened to that. I haven't read the bill that was put out, but they even described it as to the left of Bernie Sanders.
It is.
For all bill.
Yeah.
It pays for pretty much everything. There's no such thing as co-pays or deductibles. It covers almost everything imaginable. And so it's pretty comprehensive.
Doctor, I want to interrupt you one quick second to give you a little something that I think Representative, I always get her name wrong, but and I think what she realizes is she decided to do what we always do, on the left always do. We always start from a position of compromise. She decided to start from a position that can be compromised.
Right.
You follow what I'm saying?
No, and I think that's totally fine.
Okay, great.
That's totally fine.
Yeah.
Because, we're approaching it as an aspirational thing, right?
In other words, we want this. We want this, okay? But we know we're likely to have it modified. So let's tell us everything that we want so that when you throw a few things out, we really got what we want.
So I think if you look at it from that perspective, it's a good starting point. Where I have some issues with it, number one, and we discussed this offline before, there's a thing called the Rand Health Insurance Experiment, and it shows that if you take people that have coverage, if you have them get everything for free versus pay something for care, there will be a reduction in the amount of care used. And we've seen that some people, you can imagine, some people overuse care, right? Hypochondriacs or whatever. Some people use too much care. There are other people that use too little care, and we talked about them. Sick people and people lesser means have a harder time accessing care unless everything is covered. And so there needs to be a balance between those two things. But I wouldn't want to, personally, looking at the data from RAND, I wouldn't want to give everybody everything for free. I would say we should have some form of cost sharing, some modest copays. It doesn't need to be like the co-insurance that we have now or the ridiculous deductibles we have now, but we should have something to sort of get rid of the overutilization while at the same time protecting people that are sick and that are poorer so that they don't have to skimp on care that's necessary.
I want to correct one thing, however, Doctor, and it goes this way. I don't want people to say people getting all their health care for free. In other words, when that person walks into, here's what I want. When that person walks into the doctor with a health care card, it costs them nothing. When that person has to have surgery or go into the hospital, it costs them nothing. But here is the truth. The truth is that it costs them nothing at the place
at the
of
point
service.
Of service. Right, point of service.
But everybody is paying a tax.
Right.
It's in their taxes. There are no more premiums, but there is a tax, a progressive tax. So I would like to get away in the beginning from calling it everybody getting everything for free.
Okay.
Because that's not the case.
Free at the point of service is what I mean when I say that. Yeah.
Right. Now, my next question to you about the test, however, and this is an important one. You made a test that said there was better use of care if there was at least some sort of copay. My alternate question is, however, did you see a diminished results in healthcare from people controlling their use of services? In other words, did people get sicker?
No. And that's the interesting thing. So when you look at the RAND experiment and you impose this cost sharing, people use less care. Health did not change whatsoever.
That is important.
But the interesting thing is they got rid of healthcare that they thought was both beneficial and non-beneficial.
Right.
It's really impossible for something as crude as co-payments and out-of-pocket costs to differentiate between good care and bad care.
Now, you see you have data. Now, you've just sold me on that, right? Because I wanted no copay, period.
Yeah.
But I wanted no copay assuming the latter that I said.
Right.
Now, if you tell me that adjusts costs without affecting care, without affecting outcomes, then even though a lot of folks wouldn't like that. I mean, if the data says that, that's what it is.
That's what it says, and it was backed up again also in the Oregon Medicaid experiment. They took people in Oregon that were uninsured, they randomized them, gave half of the population Medicaid, half of the population stayed uninsured pretty much. And again, no difference in actual healthcare outcomes. And so it's one of the things that when you look at it, you can look at that kind of data in two different ways.
Right.
They didn't change their blood pressure, their diabetes all that much. They did get more screening tests. They were much better off financially because people aren't going broke paying for healthcare, having to declare bankruptcy, right?
Right.
So those are good things. And when they did a survey, validated surveys to figure out, are you depressed or not? People were happier. So, not being broke is probably an antidepressant.
Right. It's always an antidepressant.
Makes sense, right? But those bigger clinical outcomes, there's no difference. Now, if you're a Republican, you look at it from that standpoint, and you're like, well, why am I paying all this money for Medicaid if I'm not getting any clinical outcomes?
Right.
So people will twist the data around, too, and look at it in different ways.
I think the data is absolute. I mean, it's not about twisting the data. The data, if you want to twist it to say one thing, it just proves it proves a deficiency in your morality, but I won't go there. So altogether, your concern has to do with co-pays, etc. Is there any other concerns? I know you haven't read the bill, but based on the parts of the bill that you've heard about, are there other concerns with the concept of single-payer Medicare for all?
I think the bigger concept problem that I have is more the political part of it, not the aspirational part of it, because about 48% of the country gets their insurance through their employer right now.
Right.
And people seem to be happy with that. Now, a lot of people will complain about their insurance.
Let me stop you right there. People seem to be happy.
They seem to be happy, but they complain sometimes.
Right.
But I think people fear that transition from saying, okay, I'm going to not let my employer pick a private health plan, I'm going to rely on the Medicare program. Now, that's a political thing, and that's up to everybody's decision. Me as a physician, it's another thing. So that's from the patient perspective.
Right.
I like my insurance from my employer. I don't really want to take that risk.
What's your
switching it over
right now?
I actually have a high deductible plan. I can afford it though.
I know, but what is it?
It's like $3,000 individual. I think maybe. Actually, no, $3,000 for the family.
Right.
So like $1,500
My
for
question
the
to you
individual.
then: if you didn't have that deductible, would you prefer not having that deductible if your plan pretty much gave you more?
That's a good question. Am I still allowed to have a health savings account or not?
What's the point in having a health savings account?
Retirement savings.
No,
it's all tax savings.
No, exactly. Now this
it's all tax savings.
Doctors sometimes make me wonder.
I'm just saying, health savings accounts I think are ridiculous.
I have a health
savings
account, and that's exactly what it did.
Yeah,
my health savings account. Of course, as a political activist, folks, I've had to go into my health savings account. So we need subscribers to Politics Done Right. But anyhow, doctor, let me.
I'd rather have like a lower. Everybody would rather have a lower deductible.
Exactly.
If you could afford to have it. Yeah.
Exactly. So I mean, so I don't think, based on talking to you, I've spoken to a lot of doctors. Okay, and so far, most of the doctors I've spoken to have fallen, and the ones in my area have fallen on the right of the divide. In other words, the interesting thing is when I approach them, they like all the things that I'm saying until they realize where I'm taking them. And by the time they realize that, oh, wait a minute, what you're taking to me is what they like to call socialism. I just call it moral health care. Okay. So you just said okay.
Socialized medicine. That's what they're going to say.
They're going to say socialized medicine. Okay. I really don't care what the hell they want to call it.
Which is not really socialized medicine anyway.
Exactly. So anyhow, so your thoughts on whether we would ever be able, I know we won't get it in the next 2 years, but whether we'd ever be able to get Medicare for all?
I think there's a possibility to get it. Of course, it's going to require a lot of Democrats to be in power to make it happen.
Right.
But But I think, if I want to go back just to a little
Please
bit,
do.
talking about physicians and the overall viewpoint about Medicare for All, it's become much more positive in the past few years to have that physicians viewing Medicare for All favorably. The reason that physicians tend not to view it favorably are because they realize that income would probably go down if you implemented Medicare for All as it pays physicians
Right.
now. If every doctor got paid with Medicare right now, most doctors would lose about 10% of their income. Some will lose about 20%, especially if they're surgeons or in procedural fields. For emergency medicine, I like to point this out to a lot of emergency medicine doctors, we would go even. We would break even because we have a lot of patients. We do a lot of uncompensated care.
Exactly.
So we get compensation, we get picked up from that. We might lose out from private insurance, but for us, on net, it'd be even.
And let me tell you folks, I have no sympathy as I am talking to my good doctor here. I have no sympathy. I gave up a software company to do political activism, so I lost 90% of my income. So I don't know that losing 10% or 20% is all that bad. Anyhow, a listener wants you to tell them if preventative medicine really prevents death or serious health issues.
It certainly can prevent death and serious health issues. I mean, if you find, a tumor before it goes from, a small little lesion to a big, huge tumor that's metastasized to your brain or moved to your brain, moved to your lungs, moved to your bones, yeah, it certainly is going to save lives when you do prevention.
So Greg, that's your answer. The good doctor gave the good answer. So doctor, first of all, I want to say thank you for coming out on this bus to do the moral thing, what many other doctors have yet to do. And I know you guys don't talk against each other, but I really am very concerned that doctors of today have missed the ball, that they've missed their oath, and that they're not doing much of what we need them to do. Like there's an organization, the
PNHP.
PNHP. Okay, a group of doctors that's doing great work and that are behind the Medicare for All bill.
Physicians for a National Health Plan.
Physicians for a National Health Plan. You, by supporting what you're supporting here and being with us, thank you so kindly for being with us. That is Dr. Cedric Dark. Thank you very much, my friend. Folks, this has been the edition of Politics Done Right with Egberto Willies on the road. But thank you so kindly for being a part of the show today. And you know how I close this baby. My name is Egberto Willies. This is Politics Done Right. And I am out.
Welcome to Politics Done Right. I am your host, Egberto Willies. This is the progressive program that will take the mystery out of politics. This is the program that will encourage you to make sure government becomes we the people. Whether you are liberal, conservative, or otherwise, you get to air your point of view. Remember, you can also send me a tweet to EGBERTOWILLIES. That is at Egberto Willies. Let us engage. It is Politics Done Right.
1, 2, 3, 4.